Un petit peu sur la position de l'UNICEF. Certains messages importants qui ont été dits hier vont revenir. Donc comme nous avons été silencieux pour le feedback de la journée d'hier, je pense que certains messages vont revenir dans la présentation. Alors UNICEF, historiquement, nous avons toujours été impliqués dans l'approche communautaire. Très très tôt, nous avons appuyé les gouvernements dans les programmes de santé communautaire, notamment en Éthiopie et dans beaucoup d'autres pays. Dans vos présentations, ces 2 derniers jours, le nom de l'UNICEF est revenu souvent, témoignant vraiment notre engagement dans cette approche communautaire. Donc, initialement, nous avons beaucoup appuyé des programmes verticaux, la prise en charge du paludisme et la prise en charge de la malnutrition aiguë, pour tout doucement nous diriger vers une approche intégrée pour laquelle maintenant nous avons les évidences qu'il faut vraiment saisir ces opportunités et d'intégrer le paquet. Et maintenant nous allons même au-delà de la prise en charge communautaire intégrée avec un paquet beaucoup plus large, impliquant différents secteurs et vraiment basé sur l'analyse bien sûr du contexte et du pays. Mais voilà, nous avons fait vraiment un shift de la prise en charge communautaire à vraiment un renforcement des systèmes de santé communautaire. Alors, cette slide, voilà, notre objectif à tous est de réduire la mortalité, de réduire la morbidité. Et pour cela, il faut qu'on ait une bonne couverture et qu'on ait une utilisation. Alors, pour avoir une utilisation, il y a différents critères, différents éléments plutôt. Et donc, on a vu et on a entendu hier que les agents de santé communautaire devaient être motivés, financièrement ou non, en fonction des contextes, parce qu'il y a des profils d'agents de santé communautaire différents, certains avec des paquets promotionnels préventifs et curatifs, mais en tout cas, il faut qu'ils soient motivés d'une certaine manière. Mais cela ne suffit pas. Il faut qu'ils soient équipés, qu'ils soient formés et qu'ils soient suivis.
System strengthening, which of course underpins all of those disease control programs. Once the countries agreed on how to split the money up, they submit concept notes to the Global Fund. The HSS part can either be included in the disease concept note, or they can submit their own HSS concept note, which a few countries have done. The concept notes can be submitted anytime when there's a window. So last year we had 4 windows where they could submit their concept notes. This year there's another 4 windows, and next year there'll be 2 windows. So that, because the replenishment period is, the allocation is for a 3-year period. So they submit their concept notes, and then it goes to the technical review panel, which is an external body, which looks at the concept notes and it says, does this request make sense, and should the Global Fund fund it, and how much should we recommend the Global Fund funds? So the TRP has their deliberations. They send their recommendations to the Secretariat in Geneva of the Global Fund. And then there's something called the Grant Approvals Committee, which is basically the senior management of the Global Fund plus some of the partners, who deliberate and they say, right, we accept the TRP's recommendations and we are going to set the upper ceiling for the grant, and this is how much the country is going to get.
The USAID with MDDHA, Save the Children, GSI, IFRC, CHI, and also the 1 million the campaign, which is part of the financing task team. And so the primary focus of the task team was really to support the development of the concept note in order to make sure that we can leverage resources for ICCM, so to go beyond the malaria treatment at community level and to provide more availability of diagnosis and treatment for the other diseases, mainly pneumonia, diarrhea, which are the ones that were facing a lot of gap in financing. So since it was created, 20 countries have received the support, which and among the support was made of reviewing the strategies, developing an ICCM gap analysis, support the drafting of ICCM, and sharing some tools Concretely, it was through remote support or through providing expertise with a consultant that could come in country to support the drafting of all these processes.
One of the strengths of community health services and therefore the work of the community health worker is that it also addresses the various determinants of health or disease. Because when you are working with the communities, I remember that even from the 70s, they'd always say things like, but we don't have water, we don't have a road, we don't have education. Many of the things that we now realize are determinants of health. So I'm believing that as you work with the community health system, the community health worker services, you will be thinking about the determinants of health so that you don't make it just narrow and only focus on health in terms of disease, preventing disease, but it's a matter of preventing disease, promoting health, and providing curative services in the first line level.
So the title is A Call to Scale Up Community Health Workers. And it's called Conclusions of the Workshop on Financing Community Health Worker Systems at Scale in Sub-Saharan Africa of the 1 Million Community Health Worker Campaign, June 11, 2015. We, public health officials and health practitioners from around Africa and from international public and private organizations, businesses, and universities, have met in Accra, Ghana, during June 9 to 11 to consider ways to scale up the coverage of high-quality community health worker systems in our countries. We have reviewed the national experiences and the scholarly evidence demonstrating that CHW systems are a critical, integral, and long-term part of effective overall health systems. CHWs save lives, promote public health and well-being, and help to prevent and end epidemics like Ebola. We are pledged to work together to speed the scale-up of CHW systems in our countries and to urge national governments and donor partners to end the debilitating fragmentation of CHW funding while increasing its overall scale. We underscore the need to convert the current fragmented CHW approaches in our countries into highly effective national systems. Too many CHWs in Africa today operate without adequate pay, training, supervision, monitoring, state-of-the-art information technologies, and official authorization and logistical support to deliver life-saving preventative and curative care in their communities. The biggest obstacle to national scale-up is extreme fragmentation. The fact that CHW systems today are scattered across innumerable projects, each with its own protocols, information systems, if any, short durations, and inconsistent approaches on training and the range of activities of the workers. Very often, CHW programs are verticalized, meaning that they are part of a single disease vertical program rather than integral in the health system. They are often mistakenly viewed as short-term fixes rather than necessary long-term components of an effective health system. We call on all world leaders to heed the dramatic and exciting opportunities at hand to save lives by the millions in the coming years through professionalized, high-quality CHW systems linked to overall high-quality healthcare systems. We pledge our personal efforts and our best attempts to mobilize our respective governments and organizations in support of this cause. Signed, Accra, June 11, 2015.